Well, after some very eloquent talks this morning, I think my presentation is going to be a bit lightweight, but I do tend to be a bit more pragmatic in some respects. I'd like to go back to the classification. Group 1 carcinogen on the basis of conclusive and sufficient reason. Harmonized classification and labeling, I think, ignores a lot of clinical and experimental literature, which to me means this view should be viewed with some considerable caution. I believe that there is no statistically sound or pathologically good evidence that either of the two main forms of titanium dioxide, anatase rutile, are a cause of cancer in humans by any route. And I don't only include the pulmonary route. I believe the pathology and predictive significance of increased numbers of so-called cystic keratinizing squamous cell carcinomas, as reported in 2 strains of rat, is questionable for reasons I'll mention later. And as toxicologists, we recognize that no single subhuman species can be used as a surrogate for the human animal, for organic or inorganic materials by any route of administration. Humans are unique in the animal kingdom. I'd like to commence firstly, though, by talking a bit about titanium dioxide as a chemical. Whatever you've heard this morning, we've got to bear in mind this stuff is completely inert. It's insoluble in water, body fluids, acids, alkalis, and organic solvents. The oxygen atoms are bound covalently, and as such, the molecule is thermodynamically stable. We do know that at high temperatures, by an exothermic reaction, anatase will convert to rutile. We know in the chemical industry that the tetravalent titanium ion does not exist. So that confirms the inertness of the material. This is shown again in this next slide. The top left-hand corner is control, and cells exposed to 300 micrograms over 48 hours. And you can see here, in this bottom right-hand corner, titanium dioxide particles bound strongly within a lysosomal membrane. They're inert. Further, we know from lung biopsies, patients that have been biopsied several years after exposure to titanium, the crystalline structure of the anatase or rutile molecules is retained. And by using appropriate technology, we can identify them. So I want to emphasize to you that intercellular deposits of rutile crystals are lysosomally bound. They're not seen within any cell type in the cytoplasm. They're not present in the nuclei or the mitochondria, and I may be contradicted on this matter sometime later. And by refringency, polarized light allows identification of particle type. Now, to look at the human studies, which we've heard a little about already, I don't want you to take too much of this slide in. This next slide, sorry, this one here. A survey of the clinical studies, none is entirely satisfactory. the interpretation seen in case studies and biopsies from the clinical trials show that demographic factors, age, sex, occupational history, exposure within the titanium industry, and more importantly, exposure to toxic agents. We've heard already silica, asbestos, chromates, radon, etc., all carcinogenic. And importantly, lifestyle factors, smoking, and I'll mention that a bit later on. These clinical trials are also subject to the reliability of medical records, company records, what people remember about when and how they've been exposed to titanium in the past. Now, this next slide is a busy slide. It shows the 8 main epidemiological studies conducted in the last few years. The central column of this table is what I want you to concentrate on. No study shows unequivocally that titanium dioxide is carcinogenic in humans. Garibrandt did make this particular observation that amongst those workers with no experience of asbestos exposure, the risk of pleural disease for those employed for 10 years in the industry was 3.8 times higher than those employed for less than 5 years. The tumors we see in majority of the epidemiological studies are not clearly defined. Perfetta was the exception. He did list the tumors seen. On the left-hand side here, squamous cell carcinoma, small cell carcinoma, adenocarcinoma, and he saw an unclassified tumor. These are much in line with the World Health Organization classification of 1980. See on the 1981 on the right-hand side. Again, smoking appears. Now we know from epidemiological studies that up to 97% of workers exposed in the titanium industry are smokers. That would allow for the observation I make here. Now, we've heard some very interesting material on animal studies earlier today. I want to emphasize again that no single subhuman species, etc. But such is the controversy in the last 40 years on titanium dioxide that experimental studies have been conducted in no less than 7 species. All these species vary. Patterns of respiration, we've heard already. Deposition of the inhaled particles. The anatomy of the respiratory tract, which we've heard about. Responses to pulmonary overload, and pulmonary clearance patterns, both of which I'll mention a bit later on. These are species that have been studied at different times. The results are in some ways complementary and sometimes species-specific. Evidence of carcinogenicity is only claimed in one of these species. As far as I can see from my surveillance of the literature, no studies have been carried out in subhuman primates. But Nicola, who's done some very nice work on particles in inhalation in cynomolgus monkeys and humans, investigating coal dust, exhaust fumes, and so forth, he predicted that on the basis of fundamental studies, differences in particle clearance, anatomical features, intrapulmonary retention patterns, rats exposed to high concentrations of particles that greatly exceed human exposure concentrations should not be used to quantitably predict responses to humans exposed to far lower rates. And further, because the inflammatory and epithelial proliferative responses that seem critical for the rat response to high concentrations of particles do not occur in primate lungs expressed to environmental occupational concentrations. Nevertheless, we do have a large number of experimental studies reported in rats. The European Chemical Agency proposes that titanium dioxide should be classified as a carcinogen on the justification of conclusive and sufficient evidence in one species using Sprague-Dawley and Wistar rats. I challenge that philosophy on the basis that the rat is an inappropriate choice of species. Carcinogenicity is not established. The published reports are in many cases incomplete, and the animals are subjected to profound stress, and that stress-related pathology is a major factor in the pathology reported by Lee and others. This is an indication of the clearance rates we see in different species. Rat and mouse are similar. Hamster, the clearance rate is rather quicker. Also, notice on the bottom here, differences in the pigment grade and the ultrafine particles. The ultrafine particles penetrate in a far more rapid rate. David Warhite and others have spoken extensively and written extensively about the role of particle size concentration, penetration, aggregation, and the effect on the airways, the patency of the airways. We know that anatase, slightly larger molecule than the rutile, is more irritant. We also know that surface characteristics are important. And as I mentioned already, many of these studies done in rats and in humans, the particles are not 100% titanium dioxide, 3% impurities, which include arsenic, chromium, and so on. Now, I've divided the responses we get in the rat into three phases. In the acute phase, instillation or inhalation of the particles will be dispersed between alveolar spaces, the epithelial cells, the pulmonary macrophages, which are a constant population in rats as they get older. Also, you will get a proportion taken up by lymphocytes, dissemination to lymphatics and to local lymph nodes, and ultimately lymph nodes throughout the body. This, again, hasn't been widely explored. The result, the difference in the interspecies inflammatory patterns. Again, you see here, the rat is an unusual species. Differs from the mouse, differs from the hamster. Now, in the next phase, subacute, what you're getting here is alveolar congestion. You're getting a hypertrophy of the epithelial cells because they've absorbed titanium dioxide particles. You'll get a massive proliferation of the pulmonary macrophages. You'll also get some hypertrophy. You'll also get some degeneration. Penetration through the interstitium, increased phospholipid surfactants, and maybe some procholinergic factors. Lymph node enlargement and adenopathy. If we go to the ultimate phase, which I'll illustrate more detail shortly in Lee's work, we find profound congestion through accumulation of particles in proximal bronchioles, alveoli, and alveolar ducts. A massive accumulation of alveolar macrophages with increased phagocytosis of particles, degeneration of engorged cells. The alveoli are getting congested. Profound inflammation with mainly neutrophils initially, but later on polymorphs, lymphocytes, leading, as we've heard already, to production of the inflammatory mediators. Accumulation of titanium dioxide particles within interstitial tissue and collagen production. It's been very nicely shown by Roy Richards. Increasing alveolar surfactant, deposition of phospholipid in alveoli, and uptake of particles and lymphocytes, transfer to lymphatics, distribution to lymph nodes. All this is tantamount in the rat to pulmonary insufficiency. The animals can't breathe properly. And as I'll say shortly, this is a factor of stress, which in the rat itself can have a profound influence on the pathology. This is taken from Lee's work, not a very good paper. He doesn't show you what the controls are like, but nevertheless you do see here a profound change, dose-related change in the size of the lungs and the appearance of the lungs. This marbled appearance was a reflection of alveolar changes. You see on the right here, male and females, a massive increase in lung weight, a more than 100% increase in weight. But at the same time, you see a reduction in body weight of the animals, a reflection on stress I've mentioned already. Lee doesn't, in fact, give statistics on these animal weights. And he makes the comment that the animals were in good health, no abnormal clinical signs, no body weight changes or excess mortality in any exposed group when compared to controls. I'm afraid I find a number of aspects of this work, which is the fundamental aspect of this legislation on titanium. The papers have a number of scientific and factual inaccuracies. This is the summary of Lee's observations. You see at the bottom segment of this chart, tumors in female animals exposed to 250 milligrams per litre. Why females? I don't know. He hasn't explained it, and nobody has since. I also take issue with this paper in so much we don't know anything about the pathology of animals that died, how many animals died, why they died, and say what the pathology was. As I've said already, we have very limited detail on the body weights and the statistics of body weights. And when you have a 10% fall in body weight, that deserves statistical assessment. There are complete lack of details of the pathology of these animals other than the lung and the lymph node. Now, in a species like the rat, Sprague-Dawley, Wistar rats, 40% of those animals, maybe up to 50%, show a high rate of spontaneous tumors. Lee was of the opinion that these were irrelevant. They weren't related to dose. But, as I'll mention later, stress will promote the activity of latent cancer cells. We also notice in this study presence of rhinitis and evidence of infections. No mention through the study of infections. We know that stress promotes infection and infection-related changes. It's important also to recognize in Lee's work the inconsistency in his pathological appraisal right the way through. A simple example. He's mentioned dust cells. He's mentioned foamy macrophages. He's mentioned foamy dust cells synonymously. This needs to be corrected. More importantly, from our present observations, is the confusion he's made in the diagnosis of his tumors. At one point, he mentions squamous metaplasia. Fair enough. Squamous cell carcinoma. And latterly, he mentions this cystic keratinizing squamous cell carcinoma without definition in any part of the paper. And remember, this work was reported in 2 overlapping papers. So let's look at a conceptual framework. We've heard something about this already this morning. This was an IARC publication some time ago. The conceptual framework of carcinogenesis, if in fact it's a true story. Inhalation of the particles, deposition, induction of neutrophils and other inflammatory cells, lymphocytes, with inflammation leading to the non-specific oxygen, reactive oxygen species, with mutations, which we'll hear about tomorrow, I believe, from Dr. Kirkland, and cancers. These are non-specific. You can get them with any number of other materials in the body that are not carcinogenic. Zinc and copper, 2 examples. Now, I've questioned the diagnosis of these cystic squamous cell carcinomas. They have been looked at by many people and questioned. They're not defined in the text, as I've already mentioned. They're not a recognized lesion in the veterinary pathology. Authors found some difficulty in identifying these tumors from squamous metaplasia, because tumor cells were not differentiated and they were devoid of tumor cell invasion. Now, I haven't seen these slides, and I'll mention that a bit later on, but we know from the veterinary literature anyway that chronic bronchitis can produce a squamous metaplasia. We've got evidence in this paper, shown in the slide earlier, evidence of infectious type bronchitis. This could lead to these metaplasia and this is in a respected animal pathology book, Chubb and Kennedy, which I have a lot of respect for. I refer to these important papers relating to the cystic keratinizing squamous cell carcinomas. A working party chaired by our friend Len Levy here convened a little while ago now to look at the slides of the tumors that Lee classified as carcinomas. One tumor of all these lesions was identified as a possible ill-defined squamous cell carcinoma. All the others were consistent with squamous metaplasia, a response to prolonged irritation. A study by Cotel mentioned the growth of the lesions, which he couldn't appreciate in his study, were not consistent with those of a simple cyst. They classified them as true neoplasms. On the other hand, Ulrich Moore and his group in Canova, in the 19-dust study, looked at the carcinogenicity of a hydrophobic titanium dioxide and found no evidence of carcinogenicity. And I want to draw your attention to a paper by Gary Borman, Classification of cystic keratinizing squamous lesions in a rat is difficult. They represent a family of lesions with morphological similarities. We don't know anything about their behavioral characteristics. But importantly, if they are carcinogenic, neoplastic, we need to look at cytochemical markers for neoplasia. None of these studies have actually mentioned the cytochemical markers. So this is actually quite an important paper. So, if regulators are going to consider titanium dioxide as carcinogenic, following the high-level inhalation studies in rats, what's the mechanism? We've had some very interesting material this morning on possible routes of carcinogenicity. Because titanium dioxide, as I've said earlier, is effectively inert, doesn't ionize, I rule out a genotoxic effect. I may well be corrected on this tomorrow, some other information. The epigenetic route identified in this scheme drawn up by the IRC. Yeah, it's a possibility, but then it's a non-specific route. A third possibility, which I feel strongly in favor of, is that lesions we see are not evidence of a carcinogenic effect, but represent a hyperplastic or metaplastic response to responses to a long-term inhalation and irritancy. We know from the earlier studies the shape of the particles, the size of the particles are a constant form of irritation. We get it in the stomach, we get it in the skin. Hyperplasia, not neoplasia, but this massive keratinization. This is, I think, a probable route. But in the rat, I want to draw your attention to this aspect of stress. Stress is a major factor in the pathology of rats. And it's without any doubt whatsoever that these animals exposed to very high concentrations of titanium dioxide for long periods were subject to profound stress. And we know from other experiments, other materials, other forms of stress, that you get behavioral change, lack of movement, changes in the respiratory pattern. Remember, if an animal is stressed, it tends to huddle up, doesn't move. Oxygen deficiency is inevitable. Dietary deficiency, and we've already seen loss of body weight. And importantly, you'll get hormonal and metabolic change. These, again, not widely publicized. We know from many, many different studies in rats that stress in itself will lead to production of inflammatory cytokine release, interleukins, tumor necrosis factor, interferon, and so on. And importantly, again not emphasized, is that stress promotes immune change, depression in immune responses. And we've seen already here that animals with infection, the infection has increased in relation to the stress the animals will be subject to. And importantly, I mentioned this already, that stress promotes the development of latent carcinogenic change. We know from many, many different studies that control animals subject to long-term stress, long-term studies will develop anything up to 50% idiopathic tumors. If you've got stress, you can expect those idiopathic tumors to increase in number. And of course, as I mentioned already, Lee's studies didn't give details about non-pulmonary or lymphatic pathology, a critical omission. And we know also that stress induces hormonal change. And to quote a slightly different fact, we know that animals stressed, particularly rats, increased corticosteroid production, increased numbers of mammary tumors. We would expect that in this study, but we're not told. So I want to summarize putative carcinogenicity of titanium dioxide. We have no tangible evidence of it being carcinogenic in humans. There have been 8 decent epidemiological studies and about 20 case studies of painters, people working in the industry who've died. The pathology shows beryllium, silicon, asbestos, and no evidence of a relationship between these lesions and deposition of titanium dioxide particles. I question already the classification and pathology of the lesions reported in these experimental studies following massive overdose of titanium dioxide. And again, I'd like to re-emphasize that anatomical, physiological differences make the highly stressed rat a highly unsuitable species on which to base predictive evaluations. And finally, I'd like to conclude by questioning how correct are we in labeling titanium dioxide as a potential carcinogen in man. We've emphasized this time and time again. Titanium dioxide is administered to rats at very high sublethal levels. We're not allowed to do studies these days on these high MTD levels for 90% of the animal's lifespan. A human wouldn't survive them. So how can we consider these in our regulatory predictions? The rat is anatomically and behaviorally different to humans. Again, an important factor. And finally, comparable pathology seen in these experimental studies in rats is not seen in other rodents or species having a closer respiratory similarity, physiology to humans. Thank you very much.
Yes. 1, 2.
Okay, I'm presuming you could transfer this across to any poorly soluble particle that's inert.
Correct.
Well understood.
There is no evidence.
But I mean, you've obviously analysed the titanium dioxide data in quite a lot of detail. Have you looked at any other poorly soluble particles such as carbon black and the iron oxides?
No, I haven't.
Because I think that's quite, because we're actually challenging a toxicological paradigm here almost, or rather we're trying to find support for a long established toxicological paradigm. So I think it would also benefit if that kind of data was available, or certainly investigated.
Yeah. I think I would emphasize by saying that each of these particles is quite distinctive. The animal responses, the human responses are quite distinct. And I don't think one can draw any close parallels in the tissue or the body responses. And I think, again, a lot must relate to stress factors and immune responses. And a lot of people, I think, fail to recognize that the immune response is very important, both in the sensitivity of the animals and the responses, their inherent response mechanisms.
I just don't see why you need to invoke a stress mechanism. I mean, an approximate 10% reduction in body weight is the definition of an MTD for a carcinogenicity study. Most carcinogenicity studies will have, in the high dose, around a 10 to 15% reduction in body weight. It's well known that sustained cytotoxicity, sustained irritation of that kind on its own will induce tumors, with or without, well, usually with inflammation, because cytotoxicity itself causes inflammation. Yeah. So if you've got the cytotoxicity, you've got the inflammation, I don't see why stress has to come into it at all, because you've got enough conditions there, if sustained chronically throughout the life of an animal, to induce tumors.
I subscribe to the fact that there's a stress as an underlying factor and can have so many different influences on the health of the animal. And its inherent defense mechanisms and immune responses, cytochemical responses, and so on. There's a lot of evidence on this one.
Okay. Follow-up?
Inhalation studies in themselves are a stress, but I don't see it needs to be invoked in this way, in this manner, because there's sufficient evidence from what we can see without suggesting something that hasn't been.
You've made that point now, haven't you?
I can't elaborate on that anymore, I'm afraid.
Okay, you've made your point. You've made yours. Any other points specifically for Professor Lansdown? Yes.
Just a remark on the stress factor. Sure, on the one hand, we have the controls, and the controls might not be under stress unless at the high doses, when there is cytotoxicity and whatsoever, they are stressed then, and this may make a difference.
Yeah, it's very difficult to actually quantify stress. You probably quantify stress more by the stress-related symptoms than stress as a discrete entity. I mean, stress occurs in so many different situations. Even dietary stress. As I've said in these animals, behavioral changes are of paramount importance, because if an animal's huddled up in a corner of a cage, it's not inhaling in the same way as one that's running around the cage. This is a factor which I think is vitally important.